following presentation is sponsored by the Alabama Department of Mental Health, Lifting Life's Possibilities, and Southern Coast ATTC, unifying science, education, and services to transform lives.
We're going to look at a basic understanding of the theory of ASAM. What is ASAM? ASAM is the American Society of Addiction Medicine. That's what it is. It's an organization made up of physicians who specialize in addiction treatment. So the important thing to remember, it is a professional organization, and it is made up of physicians who specialize in addiction treatment. Just like we have physicians who specialize in heart disease, they specialize in what other kinds of things do we have out there? Diabetes? Cancer. We have doctors who specialize in every type of medicine. This is the American Society of Addiction Medicine. And as I do that, I'm going to show you some resources that you might want to take a look at in your agencies. First of all, if anybody has seen Dr. Mealy, this is an incredible video. I think it's a little over an hour that can be shown in the agency that you can purchase, and it's through Hazelton. That's one. There's another smaller book. It's called Addiction Treatment Matching. And you're more than welcome to take a look at these at any time. I'll leave them up here. So this is another one. But the actual, what I consider the Bible, is this book right here. The American Society of Addiction Medicine. And this is the one that you will really need to have in your agency. You can go on the web and just type it in. It's about $80, but it's well worth the investment for your agencies. And if you look at the last slide on your PowerPoint, I have indicated the resources, so you actually have them there. Okay? So I've included those in the PowerPoint for you. So, we know what it is now. It's the American Society of Addiction Medicine. And what are the goals for the society? Okay, defining addiction medicine, we want to do that. Improving assessment and treatment matching. And we want to educate others. That's what the society really is about. They want to educate other people to gain recognition of this medical specialty. So they have like 4 goals here to take a look at. And as addiction professionals, as LPCs, whatever our discipline is, don't we have those same goals to make sure that everyone understands what our philosophies are and our passions are in our field? So we know what ASAM is. So what is the PPC2R? And these will just come rolling off at any time. The patient placement criteria for the treatment of substance-related disorders. The patient placement criteria for the treatment of substance-related disorders. Now, we are in the 2nd edition, and it's been revised. The 1st edition was in 1991. The 2nd one was in 1996. And the revised edition was in 2001. And so you know that there is another revision out there. I don't know when it will be coming, but the authors are in the process of doing another revision. So let's take a look at why is Alabama adopting ASAM? Someone had asked that. We want to take a look at establishing a common language among all treatment providers. We want to look at that establishing of a common language because we all know what we're talking about, but we have some little changes here, some little changes there. We want to promote individualized treatment matching for our clients, improve the quality of assessments. We also want to improve the quality of treatment planning, and then, of course, the last one is to comply with block grant funding. Over 30 states right now have adopted ASAM placement criteria. And we want to be one of those states that have applied it to our state. So those are the reasons. Now what I'm going to do right now is we're going to do a little exercise on common language. Let's take a look at this bear. Here's the bear. Based on everyone's perception of the bear and taking a few minutes to look at it, or a few seconds actually, you came up with the basics of the bear, but a lot of people came up with different things, didn't they? Which comes back to establishing a common language. When I say something to the effect of outpatient, not everyone does exactly the same thing across the board. That's not right or wrong. But if I were to say I need an outpatient program, I have to understand what you mean when you say outpatient. If I need a residential program, I have to understand what you provide based on the ASAM criteria, the level of care, and the standards. Not just he has a white thing hanging down. So we want to establish a common language, right? So that everyone in the treatment field in this state says, I understand what that program provides when they say outpatient, when they say residential. And that was the exercise. So we can do it a lot of different ways. So let's see if we can begin to establish a common language. When we look at treatment concepts of the past, typically diagnosis, right? Remember diagnosis? Defined how we placed people in treatment. If you were alcohol dependent, you quite often went to 28 days. Remember those days? How many people have been around a long time and that's the only thing that was out there? So you'd come in, you'd get assessed, and we'd say, off you go. We're going to take you off to 28 days. Not 27, not 29, 28 days. Okay? And that was the standard. So our diagnosis basically defined our treatment placement. We also typically had a single model in the field. A lot of times back in the day, we only had the residential programs, didn't we? We had halfway houses. We have a lot more treatment options now, but typically there was only one model. Placement was program-based rather than client-driven. Here's my program, here's my client, you fit in here. Everybody's kind of saying, yeah, that's the way it was. What we'd like to change that from being program-based to client-driven. How many times have you heard in your careers, individualized treatment planning? How many times have you had state people come in and say, individualize your treatment plans? That's where we'd like to go, is to have individualized treatment, and we want it client-driven. And the one-size-fits-all model was basically the treatment of choice. Any thoughts or comments about those things, how we used to do it, before we get into how we will be doing it? Do you kind of concur with that, agree with that? People are saying yes? Okay. So let's take a look now at some of the difficulties we have in making appropriate treatment placement. One of the things is what? What we were talking about. The lack of availability when we look at levels of care. Sometimes someone will come into your agency and you know that they need a different level of care than you provide. You also know that the level of care they need is 200 miles away or in a different state. Does that ever happen for anyone here? In my career, it has happened quite frequently. So the lack of availability. Also, third-party payers will dictate, quite often, where we place people in treatment. This is how much money they have. This is where we can put them in treatment. And they will tell you as clinicians where they should go first. We'd like that not to happen anymore. State laws also regulate the practice of medicine for licensure, and we look at facilities requiring criteria different than we're going to see in the PPC2R. The other thing we're going to look at is out-of-pocket expenses quite often prohibits placement in a more costly level. So we continue to look at the difficulties in appropriate treatment placement. And then we also have what? A lack of qualified personnel quite often. The treatment field does not always have what we need. When we look at retooling the addiction treatment system, some of the things for patients that we're going to look at, because it's the patients that actually have driven this, it will be provided at both a cost-effective and a cost-efficient way. We want to do both. We want the levels of care to match what the person needs. We want some successful outcomes. We also want to know, are people getting what they need, and are they being able to be sober longer? Clinicians, it will be the priority. Treatment matching will be the priority, and we're going to need to perfect our assessment skills and broaden our knowledge in the field. For treatment programs, when we retool, we're looking at programs will need to expand their continuum of care, and that's why these levels are so important. We want to be able to provide multiple levels of care, not just the aviator has a little black jacket on. Okay? For payers, they will need to reimburse and fund all the levels of care. We want that to happen so that we have proper placement. Any thoughts or questions about that? Okay, here are the 6 major components. There are lots of components, but the ones that I thought was very important. We're going to look at the 6 assessment dimensions. There are, in this book, 5 levels of detox. Typically, how many levels of detox do we have now? 1. So there are 5 levels of detox. We have the individualized levels of care, and we also have what's called risk rating scales. So these are the topics that we're going to be covering in the next 2 days. The multidimensional ASAM treatment model. The first dimension, acute intoxication and/or withdrawal. The second dimension covers biomedical conditions and complications. The third dimension, emotional, behavioral, or cognitive conditions and complications. We're going to look at readiness to change, which used to be called treatment resistance/acceptance, and relapse continued use or continued problem potential. Those are your 5 dimensions. And there's one more, recovery living environment. So we have a total of 6. Total of 6. Do those dimensions look like anything in the DSM? Think about it very carefully. Do we assess in the DSM for intoxication and withdrawal? Yes, we do. Do we assess for biomedical conditions? Yes, we do. Do we assess for emotional conditions? Yes. Do we look at, now we might look at readiness for change, but we call that word denial, or they're resistant, or they're here because somebody sent them. Do we also look at their relapse? And do we also look at their recovery environment? So we're not giving up the DSM. We're using another tool to make it easier for us to diagnose. So you have your 6 dimensions. Okay, we have a handout. We're going to look at the dimensions, and I'm going to hand out actually a little cheat sheet for people. Yay, cheat sheets. And these will give you some questions to take a look at. So we're looking at dimension 1. What we want to look at are some considerations for treatment placement. Let's go to dimension 1. Considerations for treatment placement. Does the individual present with a risk of withdrawal by history? That's a very important question, isn't it? If yes, what types of symptoms have they had? Is the client presenting with current signs of withdrawal? And does the individual have a support system if detox is recommended? Yes?
Okay, it says, does the individual present with a risk of withdrawal by history? And I assume that's by their report, patient report.
Correct.
Okay, if that person is currently not experiencing withdrawal symptoms, but they have experienced withdrawal symptoms in the last 2 weeks or so, you would report that, wouldn't you?
Absolutely. You could have someone come into treatment or into an assessment who is saying, do you have a history of withdrawal? They say yes. When was the last time you drank? Last night. They're not in withdrawal in your office, but they have a history when they stop, right, that they have experienced withdrawal. Have you ever been in treatment before for detox? Let me give you an example. I was doing an assessment. I was on an assessment team, and a man came in, and he saw my colleague, and so she did a breathalyzer on him, and he had a 0.15 at 9 o'clock in the morning. And she said to this young man, she said, I really can't see you because of your blood alcohol level. What I'd like you to do is to go home, try to get some, sobriety under your belt, come back in when you're sober. Well, he was scheduled to see me 2 days later, and I knew the history, I had the notes. He came in 9 o'clock in the morning, and he blew a 0.14. Now, I could have sent him home again, but this man was maintenance drinking. He had no choice but to continue to drink, or he would go into withdrawal. I didn't send him away. We dealt with him. He was coherent, he was respectful, he was clean. All of the things that you would never know that the man had a 0.14 when he saw me at 9 o'clock in the morning. So he has a history. We are not going to send him away because he had that level. We're going to work with him so that we can get him into a detox program and have him be safe. Does that make sense? Does that help with your question? Okay. Let's look at dimension 1 a little more. There are 5 levels of detoxification services in the PPC2R. Okay, 5 levels. Not just inpatient, and these are the levels that I get very excited about because for me, these are very important. It can be provided unbundled. In other words, someone can go to a detox program, get detox, but that doesn't dictate where they go for treatment. Some people might need an in-house, hospital-based detox program, but that doesn't mean they need a 28-day program. They don't need a residential program for treatment. The levels of detox services does not dictate placement, and we will take a look at some of the detox levels. D1, level, or 1D, I'm sorry, level 1D, mild withdrawal. It's ambulatory detox without extended on-site services. We're looking at a physician's office. Have a little people going, what would that be? What would that look like for someone who would go into a physician's office for detox? What might they be withdrawing from? Pardon? Prescription pills? How about opiates? Prescription pills? We know about Suboxone, correct? A physician-based detox. We're looking at level 1D for mild withdrawal, level 2D for moderate withdrawal. And this would be like a day hospital. It's ambulatory. People go, they see the nurse, they see the doctor, they have their medications checked, but they go home at night. And this is when we were talking about the question, do they have support at home? They might be appropriate for this level. Level 3.2D is moderate withdrawal, clinically managed, residential detox. It's a social setting. The important thing is clinically managed. 3.7D is medically monitored. You might be in a freestanding clinic. And a level 4D is severe unstable withdrawal, hospital-based. So the difference is ambulatory versus clinically managed, medically monitored, and medically managed. Has anyone in here ever been exposed to any of the different levels of detox services? Yes. Okay. That's an excellent question. Where would this person be most appropriately placed, correct? Now, I don't have a very simple answer, and the reason is when we get to tomorrow, we're going to look at what's called the risk rating scales, and the risk rating scales will help you determine the levels of detox. So I wish I could give you all of that information, but it's very, very extended. So we want to make sure that we don't get too far ahead of ourselves. But the risk rating scale will. But very simply, if you have someone who has a history of seizures, we're certainly not going to put him in a physician's office, are we? Where would we want to put a person who has a history of seizures? In a hospital setting. So we want to take a look at the specific signs and symptoms that they can report to us. When you have someone who is withdrawing from opiates and we look at a physician's office, that's one way. The other one we can look at is like a methadone program. They don't have on-site monitoring every single minute of the day, right? When we look at the day treatment hospital, what we were looking at is sometimes this particular unit is within a treatment center or within a hospital, but they don't stay overnight. They don't have significant signs of withdrawal that would be dangerous. They don't have a history of seizures. However, what we always look at, and this is the really true beauty of the ASAM placement criteria, is that people can move up and can move down as their symptoms change. So if we bring somebody in and we feel that they could be clinically managed at the 3-2D, but that isn't helping them right now, they are presenting with significant issues, we're going to put them in a level 4D because we want the safety of the client to be foremost. Other questions?
Will you define social setting on that level 3-2D?
The 3-2D, the social setting, what you're looking at clinically managed, so you would look at folks like us, treatment providers. It might be overseen by a doctor, but it's not on site. You might have peer support. So those are the social setting ones. You're not in a hospital, but more you're clinically managed. Residential program, you're in a residential program, but the folks that are looking after you are clinicians rather than doctors. The doctors are available, but the social setting is more about peer support and clinicians. Yes?
And the difference between that and a freestanding center?
The difference is if you look through 3D, okay, 3-2D versus 3-7D, you've gone from clinically managed to medically monitored. And you're going to see the definitions of those in just a minute. So you'll be having a clear understanding of the clinically managed, the medically monitored, and the medically managed. And that's the beauty of ASAM again, is they have basically taken this and broken it down very simply. Dimension number 2 is your biomedical issues. Some considerations for treatment placement is your current or acute physical illnesses. And the important thing is not withdrawal. We do not address withdrawal on Dimension 2 at all. Dimension 1 handles all the withdrawal. You're looking at chronic medical conditions and also pregnancy issues. Dimension 3, emotional, behavioral, or cognitive conditions and complications. Things that we're going to look at in Dimension 3 are things like psychiatric conditions, or we're going to look at poor impulse control issues. We're going to look at recent changes in our mental status, psychological or emotional or behavioral conditions. Now what we want to look at, sometimes we know why those are happening and sometimes we don't. So we want to make sure that sometimes, right, that we look at why the conditions are presenting themselves today. The one that I want you to also think about is the behavioral issues and the cognitive issues. We're not just looking at diagnosis like schizophrenia, bipolar, major depression. We're also looking at behavioral issues and cognitive issues. Can someone come in with a cognitive issue that is not going to clear up just because a person stops using? Give me an example of some, pardon? Schizophrenia. Think of something else under the cognitive issues.
History of abuse.
History of abuse. How about something like traumatic brain disorder? Right? So you can look at those cognitive issues that really probably will not subside when the person stops using the chemical. They're going to be there, and we need to continue to address them. Does that make sense? So we also want to look at some of those neuropsychiatric issues that are transient. They come and they go, depending on what's going on in a person's life. So we've learned about 2 dimensions so far. First one was acute intoxication and or withdrawal, and the second one was biomedical conditions and complications. And the big difference between the two is if you're looking at withdrawal, that doesn't fall under biomedical, which is dimension 2. It falls under dimension 1. Okay? Now, let's look at dimension 4, which is readiness to change. And most people have been around and seen a lot of motivational interviewing. Has anybody been to a motivational interviewing training? Yay. So you're pretty familiar with motivational interviewing. But the component that we're going to talk about here is readiness to change, or the stages of change. This was Prohaska and DiClemente. We have pre-contemplation, contemplation, preparation, action, maintenance, and relapse. Okay? You're familiar with those? Heard those before? Been around? Okay. So, what I'd like to talk about right now is pre-contemplation. Pre-contemplation is not considered a stage of change. Even though it's included in the definitions, it's not a stage of change, and the reason is the person doesn't see the need to change. They have no idea that there's anything wrong. In fact, to the point where it's got to be your fault, not mine. So pre-contemplation is the point where the person doesn't see a need for change, either in their lifestyle or in any behavior issues in their life. When we look at contemplation, the person is ambivalent to change. Sometimes they want to change, sometimes they don't want to change. They're considering making a change, but they've not quite decided when. Anybody in here ever been in the contemplation stage in anything in their life? Anybody feel free and open enough to say what that might be? Divorce. Not sure if you heard that in the back, but the divorce issue. Never heard that, but she has been in contemplation, and have you moved forward from that? I'm not in relapse. Okay. She's not in relapse. All right. Okay. Anything else where you've seen contemplation in your own life? Diet. Diet. Hey, like diet. Anybody else?
Job change.
Pardon?
Job change.
Job change. You can be in contemplation. What else? Retirement. And what was this one? Marriage. Okay, so she's at the divorce part, you're at the marriage part, so we're looking at the contemplation in many, many different ways, correct? Anybody else share one for contemplation? Education, meaning wanting to go back to, you want to go back to school and not sure if this is the right time. Sometimes you think yes and sometimes you think no. Good examples of contemplation. Preparation. A person has decided to make a change, okay, and they're doing some things to look into following through with that change. If you don't mind, I'd like to call on you. School, you were talking about education. What would preparation look like for you? Checking into financial aid? Curriculums? The closest of the school? Do they have the courses you want? Those are the kinds of things that people do when they're in the preparation stage. Action, the person is actively engaged in the change process. They're doing something all the time. They're not thinking about it, they're just doing it. And the maintenance phase is regularly engaged in the new behaviors. And then, of course, we do have the relapse and the recycle stage of change. Let me give you a little bit of an example that I would like to tell you about regarding, let's say, dieting. Person in pre-contemplation says, I don't really think I have a problem with my weight or the way I eat. But I go to the doctor and the doctor says, Barb, you know what? Blood pressure's a little elevated and the cholesterol isn't looking too good. I'm thinking we better take a look at this. And I'm saying, look, I've been doing this for 50 years. I'm okay with it. Not a problem. Doctor said, I'm just telling you. So we go back 6 months later. The weight's gone back up, right? The blood pressure is still a little high and the cholesterol has now gone off the charts. So I look at the doctor and I say, maybe you're right. I'm going to think about this. So I'm in the contemplative stage. Not sure yet, but I'm thinking about it. Well, all of a sudden I'm thinking maybe the doctor's right. And so I prepare. Maybe I get some books on weight loss. I change my diet. I go see a dietitian. I'm doing all of those kinds of things. And I begin to have a new diet, new lifestyle behavior, and now I'm in the action phase. And it falls right into the maintenance phase because my diet is going well. I'm enjoying the way I look. The doctor says to me, the cholesterol's down, the high blood pressure is down, and I'm feeling really good about this. And my husband gives me a surprise cruise. He's going to take me on a cruise. Do you know how much food there is on a cruise? They have food all over that ship. And what do you think happens to my diet and my good intentions? I think I'm on a ship. Who's going to know? Obviously, it's there. They want me to eat it. A lot. So what happens? I relapse, correct? And I come home and I'm not real happy with myself. Pardon? I reschedule my start date. There you go. So can you see how this can happen? So let me show you something here about the stages of change. When we look at the stages of change, you can see that pre-contemplation is out of the circle. And a person will start there and usually go into the contemplative stage. And preparation, action, maintenance, or the stable behavior, and then they might relapse. Doesn't mean they have to. However, they don't have to go back to pre-contemplation if they relapse, as in the cruise and the food. I can go right back in to the action stage, go into the maintenance stage, and stabilize my diet again. Thoughts or questions about that? When we look at clients who come into our office, quite often they can be in the pre-contemplative stage, they can be in the contemplative stage, but they also can be in two different stages at the same time, depending on their drug of choice. Have you ever had a client who might come into your office and say, cocaine has been an issue for me. I've been arrested. My children are in jeopardy of being taken away from me. You need to help me stop using cocaine. But my alcohol is not a problem. Does any happen for anyone in the field?
Oh, yeah, mostly marijuana.
Mostly marijuana. You're saying marijuana isn't a problem because what is marijuana? It's just an herb.
God put it here.
Pardon?
God put it.
God put it here. But what I'm saying is you can have someone on different drugs who are in different stages of change. They don't want to change one, but they want to change another, and that can be very, very challenging. Thoughts about that and how we work with clients like that? So let's take a look at the concepts regarding stages of change. Resistance typically is what? It's an expected part of the treatment process. People come in, sometimes they really don't want to be there. Very seldom do you have someone who's coming in, raising their hand and say, yes, yes, I want to be here. In fact, I want to be in treatment for 7 years, right? They're very excited. Typically, we find people who come in because the husband, the wife, the DHR worker, the judge, the CRO, the work, it doesn't matter. They come in because someone else has encouraged them to do so. Resistance does not exclude anyone from coming into treatment. We use that old word, denial. That doesn't exclude someone from coming into treatment. The other thing is the degree of readiness to change helps determine the level of care. And you'll see that as we begin to look at levels of care. Now, if I'm not mistaken, we're going to have a handout and a group exercise. So this is where the group will get together. And these are motivational interviewing vignettes. What I'd like you to do is to look at each one of them and see if you can figure out what stage of change the person is in. Let's take a look at some of our vignettes. Okay, let's take a look at Steve. Remember, Steve was sent to your agency, and I'm going to ask, I'll just read this. He has come for substance abuse treatment. He feels hopeless about his drinking. Both of his parents were alcoholic. He knows that the disease has been passed along, so he has some awareness. His mother died of liver failure, and his father gets drunk the first thing every day. Steve sees no hope for himself. So he says he's tired of professionals telling him that he can change when he knows he can't, and he's tired of people acting nice and hopeful for him when it's just a setup for him to feel more frustrated later, which ends up making him drink more. So give me some thoughts before I tell you the answer that I came up with. Pardon? Pre-contemplation. And anybody else have pre-contemplation?
We had both. We had pre-contemplation and contemplation.
Okay, because he vacillates between the two. And what was the cue that gave you the pre-contemplation and the contemplation?
He has asked other professionals in the past.
He's asked other professionals in the past. He's aware that there's a problem, right? He knows that it is a disease, so he's pretty aware. Let's see what we have here. Contemplation. He's thinking about it, but he's feeling pretty hopeless. Now, if anybody said pre-contemplation, I wouldn't argue with you either. Remember, some of this is somewhat subjective, and you have a little tiny vignette that you take a look at. But he's contemplating because he's come into the agency. All right? Now here's Daniel. He's been absent for 10 days, stayed home, slept. He went to AA a few times. He's proud of himself, but he feels like he has to find more options because he's beginning to feel somewhat bored. And he would like help learning more about what he can do to stay abstinent. Thoughts about Daniel? Preparation. What else? And action. He's doing something. He's preparing. He's also in the action phase. We know he's not in the pre-contemplative phase, don't we? And we know he's not in the contemplative phase because what's he done? He's beginning to do things. So let's see. Action. Now that's not written in stone. He can also be in the you can look at, he's at the high end of pre-contemplation falling into action, but he is doing things. Let's take a look at another one. Good old Margaret. She's considering cutting back on her pot smoking, isn't she? She doesn't feel like it's a problem, but she believes she better cut back because she's recently taken a job that requires her to do a considerable amount of public speaking. And she perceives that her public speaking is a lot better when she hasn't been smoking a lot of pot. Okay. On the other hand, she wonders if she might be keeping those late hours that is impacting her ability to speak publicly. So her friends and her late nights are causing the problem. So she would like to be a better speaker, but she's thinking maybe it's the pot or maybe it's the late nights. Contemplation? Good. Right. She'd like it to be the late nights so she could continue to smoke the pot. Toby, he's been drinking a considerable amount of alcohol, somewhere between 4 and 5 times a week in the last 6 months, and his friends have noticed that he's having some personality and mood changes. They've tried to talk to him about them, but he continues to defend his behaviors and assures them that he does not have a problem. Pre-contemplation. Let's take a look at Cheryl. She successfully completed a substance abuse 1 month ago. She's attending self-help meetings. She has a sponsor. She wants to make sure that she doesn't relapse and is exploring ways to maintain long-term sobriety. Maintenance, action, maintenance, more on the maintenance side, more on the action side. What are you thinking? Maintenance. Action. Okay. Let's see what I said. Maintenance. That doesn't mean I'm 100% right. That just means that's what I chose. So she's looking at ways of maintaining and staying sober. Tawana says she's been thinking a lot about her cocaine use lately. She's never felt anything as great, not even sex. So she's pretty committed to this. But she's feeling like things have gotten somewhat out of control. Okay? She's been trying to quit for the past 2 months, but she has given up due to repeated failures. She came to you in a last-ditch effort to quit. She doesn't know what to do. Every time she quits, she feels great for about a week, and then she feels too overwhelmed or too depressed and goes out and gets high again. Preparation, what else? Going into action. Preparation, most people are contemplation. Let's think about it, and I could be wrong. Has she really done anything yet? Is she contemplating doing something? So she has come in and said she's tried, right? But she's fallen back. I said contemplation only because she's vacillating back and forth. But if you said preparation, I would go with that also. Let's take a look at another one. Sharon's been concerned about her alcohol and drug use for the past 8 months. She called a counseling center in her community. She's made an appointment to talk to a counselor, and she's also called AA and NA and requested information about self-help. What do you think about preparation? She's preparing. John has been in treatment before and was able to stay sober for about 6 months. He recently relapsed for about 5 days. He called his sponsor and immediately attended self-help. He also called his old counselor and made an appointment so he can get back into substance abuse programming that he attended in the past. Now this one's a tough one because we know what? That he's relapsed. And we know he relapsed for 5 days. But what did he do? He called for help. Now he can be in, these are the things that we can take a look at, action. Because he's going back into, right away, all of the things that he was doing before. Okay. Okay, I have a question here, is why is it not relapse and recycle? The reason I said action is because he did relapse, but he had been in treatment before and he was in for 6 months. If you would like to put relapse, recycle, I would not argue with you, but he has gone from that right back into the action phase. Okay, what is the recycle part? Is when you begin to come back through that circle and go back into another of the stages of change. He is. And I'm not going to argue. That is not, I'm not saying that you're wrong. I'm not saying I'm 100% right. The way I looked at it is he recycled, but he came right back into the action stage. Now let me explain something to you. The new assessment tool will help you do that. Okay? The new assessment tool has a part of it is built in where you will be able, based on questions that they will ask and answer, that will put them right where you need them to be. The other thing that I would point out to you is there is a tip, and it's number 35. Are people familiar with the tips? You can get them for free. It's a whole thing on motivation and change that you can use. Yes?
So recycle is not really a definite stage, like the other stages are.
It's a definite stage where pre-contemplation is not a stage. Relapse and recycle is a stage because something is happening in there, whereas with pre-contemplation, nothing is happening. But when you look at each one of the other ones, something is actually happening. So yes, you have that recycle, relapse phase. The reason I chose action for this guy is only because he came right back in. So that's why I chose it. If we made it a little different and said that he didn't call the sponsor, hadn't called his counselor, hadn't gone to a meeting, then he would have been in that relapse phase. Yes. The question is, if you have someone who is attending group, he's very consistent, he talks when he's in group, however, he continues to test positive.
Is he in group because he wants to be?
Is he in group because he wants to be? You work with court-ordered people. Some court-ordered people want to, some after they get there, they decide they want to be there. So help me with this. What do you think the stage of change would he be in?
Well, what's the drug of choice?
Cocaine? Okay, the drug of choice is cocaine. So let's think about this for a minute. We have a client, comes into treatment because he's court-ordered. Okay? Now, he comes consistently to treatment. He's compliant. However, he continues to test positive.
I might even say he's preparation.
Preparation is one, yes?
I think I would say pre-contemplation, unless he's like, I'm coming here, if he's not thinking about it.
So we have pre-contemplation, contemplation because he's doing something, but he's not committed.
I'm saying pre-contemplation.
Pre-contemplation, okay? Yes?
Yeah, I would say a determining factor will also be, even though he's showing up in group, is he actively participating? Because if he comes and not saying anything, then that really doesn't count. So if he actively participates, they kind of change it a little bit. He's participating.
He's participating. So this is an actual client. It's court-ordered.
I have a question. The quality of the participation. Are we argumentative? Or are we accepting of the fact that we have a problem and talking about triggers?
Let's go with accepting the fact that we have a problem. But still use.
But he's still using. So I think what somebody said back here was pre-contemplation. He's ambivalent. Contemplation, okay. What do you think about contemplation? Contemplation? Some people said preparation. He's doing something.
He's doing something that he's forced to do.
He's doing something he's forced to do. So he's riding that teeter-totter, isn't he? He's doing what he needs to do behaviorally, but he's not committed to stopping his drug use. What do you think? That's a very difficult scenario.
And it happens
All the time. Yeah. When you have mandated clients, some of the mandated clients will come in and you know that they are in really pre-contemplation because they don't think they have a problem, but the court does, or the wife does, or the husband does, and they come and they do all the things they're supposed to do, but their behavior never changes. So do we successfully complete those folks?
We don't.
You don't. Okay. One of the things that you're going to find as we get into the levels of care, all right, is that there will be a place for people like that. Believe it or not. You're going to be able to place folks based on their stages of change, okay, and their participation. And that's a very exciting piece. Let's take a look at dimension 5. We're looking at relapse, continued use, or continued problem potential. One of the things, or some of the things we want to look at is there any immediate danger of continued severe mental health distress and or alcohol and drug abuse? This is the first time that we've heard about mental health issues, isn't it? Because ASAM incorporates mental health issues, and we will be doing risk ratings on those. Does the client understand or possess the skills necessary to cope with the addictive or mental health disorder in order to prevent relapse? Also, what level of awareness does the client have of relapse triggers? And we want to look at both substance abuse and mental health issues. And what skills does the client possess to cope with or control their using? Or what skills does the client possess to control the impulse to harm themselves or others? So when we look at this, relapse, continued use actually addresses both mental health issues and substance abuse issues. Does anyone in here work with the co-occurring population specifically. We all work with co-occurring folks, but specifically. This dimension right here will help a lot when we're looking at relapse triggers and relapse potential. Do we have relapse triggers for substance abuse? Do we have relapse triggers for mental health issues? Can someone be stable on the mental health side but be unstable on their substance abuse side, or vice versa? It will happen. People will be taking their medications the way they're supposed to sometimes, but their substance use is out of control. Or their substance abuse is stable, but their mental health issues are out of control. And so when you look at dimension 5, this is what you're looking at. These are some of the considerations for dimension 5. When we look at dimension 6, let's take a look at some of the areas that we will be looking at. And this goes back to Access 4. This goes back to the DSM. Problems with primary support group. We also want to look at their social environment. We want to look at educational issues. We want to look at occupational issues, housing issues, economic problems, legal problems, transportation issues, and child care issues. This is a very comprehensive dimension. Do we do this now? Yes. Okay. All we're doing is renaming it and saying this is dimension 6. That's all we're doing. So let's stop for just a second and review the dimensions. So dimension 1, anybody? Acute intoxication or withdrawal. And we talked about how do we make those determinations. Some of it is their history. You want to get their history. You also might want to get some collateral information from friends, spouses, anybody else that you can think of. Do they have a potential for withdrawal? The second dimension, give me that one, please. Biomedical conditions and complications. We want to look at acute illnesses as well as chronic illnesses, don't we? Does this dimension incorporate withdrawal? Can it incorporate pregnancy? Sometimes we know what the cause of the biomedical conditions are, and sometimes we don't. So we really have to explore those. Dimension number 3. Emotional, behavioral, and cognitive issues. We want to incorporate all of those. In the past ASAM placement criteria, they didn't incorporate all of those. They looked specifically at the emotional issues. Now they've brought in the cognitive and the behavioral issues. So that's when we start looking at our mental health pieces. And then dimension 4 is readiness to change, stages of change. And we know that there are how many stages of change? Count them for me. Did you include pre-contemplation in those stages of change? No. Pre-contemplation is not a stage of change because there's no change going on. So it's what? Contemplation, preparation, action, maintenance, and relapse, recycle. So there's your readiness for change. Now, dimension number 5 is what? Relapse or potential or continued use issues. We want to look at a lot of those things there. We can look at both the mental health side and we can look at the substance abuse side. Dimension 6 is your recovery environment, and there are a considerable amount of things to take in consideration there. And that can be for the mental health and for the substance abuse. Thoughts or questions about the 6 dimensions? Do they make sense? Do you think that when you use them that you can be able to do a more comprehensive assessment if you look at all of those dimensions? You can also use those dimensions in treatment planning, because if you have an area where there's significant issues, what would come first on your treatment plan? That dimension, right? If you had someone who was in the potential for withdrawal, would you want to address that first on your treatment plan? If you had someone who was living in a toxic environment and they were having difficulty remaining sober, what would we want to look at? We would want to look at dimension 5 and 6, because 5 is talking about relapse and 6 is talking about the recovery environment.